since we did like a full scale focus on pain, and I love the information that the way you explain pain to people, just I think relates for a lot of people. So thank you for doing that. But I thought I would kind of start this off with a little bit of a twist. Okay. So for you, what's the most intense pain experience that you kind of remember in your own life?
Oh, I totally have a story about this because my husband is a snowboarder and I was not, and I tried to learn as an adult, and I went, I sort of learned it enough to go down the green hill. There's the different colors. It was really not a green hill, and there was sort of this repeated whiplash situation that happened all the way down the long hill. But I just remember this unremitting neck pain that I had that was really acute for, of course, like a few weeks, and then sort of never went away for a long time.
It's so interesting whenever when we look at some of those things. So I'm sure at the moment, you're trying to figure out like what's going on with your neck and what happened, what did that cause? How do you explain what your body was doing in those weeks after, and then beyond that now looking back? How do you explain that?
Oh, I think there's a lot of things that contributed to this sort of story, but in the moment, I think my body was a signal, right? That something is wrong. If we think of pain as sort of a guiding signal that is communicating to us to motivate some behavior. And so for me, the next day, that meant everybody else continued to ski and snowboard. And I stayed home and iced my neck, and I rested, and I, barely got up to make chili for everybody. Right. And then for the few weeks that followed, that signal stuck around. And it stuck around for me personally in the context of a really stressful, sometimes toxic, fast-paced job at a medical center, in the context of a lot of life changes at the time. And also in the context of a lot of fear, because that was the first time I ever had pain that didn't go away within a few days. I had never broken a bone or, I'd never really had an acute injury before. So I also kind of had started to develop really early on a lot of fear about it.
Yeah, it's always interesting, even knowing some of this stuff, and as we talk about it, and I often will tell this to patients whenever we're working with them, it's like, it doesn't, in my situation, you can know it, and then it's a whole different thing to know it while you're experiencing it. Yeah. And then it's the old, Mike Tyson idea, like everybody's got a plan until they get punched in the mouth. Like when we have pain, even as educators and practitioners, that's you getting punched in the mouth. Like, can we put all these thoughts into action while you're actually in the moment of dealing with pain? And that's the difficult part for us even. So how difficult is that for our patients who, maybe don't have the base understanding of some of this stuff?
Absolutely. And it was really interesting to experience sort of long-standing pain alongside that of because I was working clinically at the time in this hospital. So alongside that of my patients and trying to use the things that I knew should be helpful. And, after a while, kind of seeing those same things that we were using with patients not really working.
Were you kind of like focusing in this world? What ended up, did you shift into kind of your current, focus of pain being kind of the primary thing, along the way? Was that something that you were starting to get interested in? How'd that process come about?
My goodness. I started working with pain way back in my fellowship, and doing a lot of CBT, cognitive behavioral therapy for chronic pain, running a lot of groups, doing a lot of individual therapy. But it was and for my own pain, I went to the doctor and went about it in a really traditional way, like most people would. But it was sort of at the point where it started to become chronic, 6 months later. I also accepted a new role in treating pain where I was the director of this interdisciplinary pain program. And I remember that being a really critical point in being a a practitioner that worked with people who had pain. I worked with a physical therapist at the time and an occupational therapist, and they were doing a lot of education around pain neuroscience and really helping to neutralize pain for people and reduce the fear. And I remember kind of, I knew a little bit of that and I knew about neuroplasticity, but I remember kind of taking that in myself alongside my patients at the time. I'm so sorry about the dog. I don't know why she's so worked up right now. She must really like
She's excited about pain. I'm with her.
But I remember taking in that education and just feeling like I slowly thought about my pain less. I started to fear it less clinically and personally. I slowly started to think about it less. My mind slowly became, kind of bigger than my pain over time. And I remember that sort of being a critical place for me in terms of being a practitioner of pain.
I definitely want to dive in that. Let's kind of zoom out a little bit.
We're going out in different directions.
So let's kind of start here, because I think it's something that a lot of people maybe have a little bit of a misconception. Like, how do you think of pain's function in the body?
Yeah, thanks for asking. That's a really important question. And I know lots of people explain it differently. For years, I think pain was really thought of as a measure of tissue damage, which makes a lot of sense when we're talking about acute pain that might follow an injury. But pain, we think of pain as a signal, right? That something is wrong or something needs to be addressed immediately in some way. And we can often resolve acute pain or that type of pain, especially if someone's had it for less than 3 months. There's a lot of really great treatments out there. But what happens when we depend primarily on telling patients about how their spines work and relying on these conventional medical treatments alone, and when pain doesn't go away, those people can look to feel really marginalized, like no one believes that their pain is real. And I think with so many people suffering from chronic pain, it's really important to understand pain a little bit differently as something that's more complex, that's multidimensional, that's more than just a signal that something's wrong or a measure of tissue damage. And so I think for me, when I talk about pain, when it's chronic, I say that it's helpful to think about it as part of a complex and sophisticated protective mechanism or apparatus in our body, a threat detection system that's really based on an evolutionary need to survive. And that pain itself is really important. Like I said, it's this guiding behavior. It motivates us to take action, to keep ourselves safe. It keeps us, to keep us from, using that arm when it's broken or removing our hand. It causes us to kind of remove our hand from that hot stove or whatever's burning it. And when we're navigating through our lives, we're essentially doing two things, right? We're looking for rewards, we're looking toward rewards, and we're looking to avoid threat. And our threat detection system allows us to do this. And so in order to work well and keep us alive, it has to be able to predict to some degree. And if it wasn't able to, or at least trying to predict, then we'd be reacting to every stressor along the way. And that's just something that's not sustainable. So when I talk about pain with people, I talk about the brain's role, that it's our brain's job to predict where these threats are. As we know, it's hard to predict. None of us have these magic crystal balls that predict the future. And so sometimes our threat or pain detection system can be off base sometimes. And so here's how this works. And I think this is the important part for people listening. So I guess if they're multitasking, come back to us, because, if we can think of pain as an alarm system made up of the brain, our spinal cord, our nerves, our sensory receptors, or danger detectors, those detectors are placed all over our body. They act as the eyes of the brain, whose job it is to protect us. They send messages from that affected area to your body, through the spinal cord to your brain. And then your brain uses all this information it has, all this input, past experiences, memories, mood, emotions, trust, feelings of safety, your senses, and it produces pain if it thinks we need to be protected. And so sometimes that's damage, sometimes it's an injury, and sometimes it's something else. But it's all about what the brain is perceiving you need in that moment. And the important piece is really trying to figure out why someone's brain thought in producing pain would be beneficial or was necessary in that moment.
Yeah, it's one of those things, and I talk to patients about this, and I think in some way it gives them comfort, and I think there's probably some patients that would say that it frustrates them, but a lot of times we'll talk about the early stages, that the longer that the relationship between pain and tissue continues to weaken, the longer pain is there.
Yeah.
So the longer that we have pain, the weaker the relationship between that pain and tissue is. And so whenever we tell somebody that, and they're in their 2 months, I'm like, look, so here's how we identify the tissue that's damaged. If I tell someone that and it's been hurting for 2 years, I think there's almost some kind of relief in some instances if they've looked at some of this. And there's probably times where they say, like, well, then what are we working on? What are we going to fix? How do I get past this? Just because, like you said, there is so much of a focus, not just in medical education, but I think in our kind of social education of the kind of biological effects of pain, that type of theory. I think most of the time, if you heard a layperson talking to another layperson, they're going to talk in biological terms. You threw your back out, it's a disc, that's probably a pinched nerve, you strained a muscle. Like, it's always going to be in the kind of biological world, and we just don't do a great job of mentioning that that changes at some point. That starts to shift a little bit, at least not to society as a whole, so.
And I think it matters who says it, right? So as a psychologist, even still with all the stigma associated to seeing someone like me, it's really different if I say it versus a physical therapist or their physician that they trust, right? And it does all sort of come back to biology, and it's important not to swing the pendulum too far in one direction when biology is a hugely important part of all this. But I also feel like it's so important who that message comes from too, because the patients, especially because of how conventionally we approach pain, they go to their physicians, they go to the people who they think will treat them physically. And if those people can say this, or at least introduce them to this idea, it makes my job a lot easier.
Yeah, they probably come to you like, well, of course you would say that. Like, you're a psychologist. They come to us and they hear it, and it's almost probably takes them back a little bit.
It does. We have to build a lot of trust there, because then the step after that is, like me telling them, what I am saying is the thing that's continuing to drive your pain is how threatening we think the pain is, right? And I have to move them from the brain to sort of the mind a little bit sometimes to kind of see how that cycle is being maintained.
So you mentioned this. Let's kind of dive into it, and then I want to kind of tie this to what you're talking about with, like, the threat that the brain is perceiving. So the way that we explain pain, it's very interesting. I'll fill you in on this. So I'm like in the editing phase of a book, and I wrote a whole chapter on like the history of pain that will not make it in. So it was like, not that it was wasted. It was very fun to write, to go back and see like how our belief around pain impacted directly the way we treated people, the way we treated pain. And this goes back to where, like, initially we thought it was, bad spirits. And so what did they do? They did ceremonies for these people. Then they thought it was bad energy. Well, we got to get it out. So we start drilling holes in people's heads and trying to let the bad energy out. And then that continues to progress. And, it kind of, the belief around pain directly reflects the treatment around pain by and large throughout history. So what's the current kind of pain model that is most accurate to you?
I think the best way to think about pain is thinking about it from a biopsychosocial standpoint, because, like I said, I think, we're all trying to figure out the answer to pain, and there isn't just one answer to pain. So it's important to include all of the aspects that impact it: biological, psychological, and social. It's not a very trendy name, but I think that's the approach that I always take. Because can you
like, if you were given the biopsychosocial elevator pitch, so like, can you give us what that means to you? Like what does that mean about pain if we're using that to explain it?
Yeah, absolutely. So when we think about, so if you think about science and research over many years, and this isn't just like a decade, this is decades of years, they've told us that the mind and body are not separate. So I'm sure when you dove into the history of pain, you noticed that there was a period of time where people were really separating mind and body, that pain is a signal, it's a measure of damage. The amount of the hurt that you feel depends on how much damage you have, regardless of what is happening in your brain or your mind. And I think conventional medicine still approaches it that way a lot of the time. They have this interesting approach, this idea that someone with physical pain should be treated with a medical or physical approach, and someone with emotional pain should be treated with a psychological approach. And I think what I'm talking about here is this idea of treating pain as if the body and mind are separate. The idea that pain lives only in the body because that's where we feel it, and we should treat it biomedically like it's something purely physical. But we know from science, research, and common experiences that pain is actually this experience created by our brain, and it's also impacted by a number of factors that are unique to each of us. It's not just a physical phenomenon. Because think about this, if you and I both had, x-rays done, and those x-rays showed that we both had mild arthritis in the same area of our spine, but I'm reporting severe pain and you're reporting no pain at all, what accounts for those differences in experience? And the answer is our brains and all of the things that make us unique from each other. So this biopsychosocial model views pain as living in the overlap of biological, psychological, and social factors. So biological factors are things like genetics, anatomy, our body structure, system dysregulation, sleep, nutrition. Psychological factors are things like our emotions, our thought patterns, our coping behaviors. And we know that things like mood and emotions are always changing the pain experience, because pain is processed by the limbic system, or the emotion center of the brain. And coping behaviors also fall in this category. Things in particular like avoidance are really important there. And then the social factors, these are things like culture, current and past social experiences, with others, our work, the context that things occur in, our environment, our culture, pretty much everything else. And I think I like to use this model as just a way to be inclusive of everything, like the whole picture of chronic pain that can impact it. And when we think about how these factors impact our pain, we can think of it as like the volume control on your phone, that when the volume is low, the nervous system is calm and pain is low. When the volume is high or turned up, our pain is higher, our nervous system is more activated. And a lot of these biological, psychological, and social factors, some are outside of our control, like our genetics. We can't necessarily control that. But some are totally within our control. And when we look at a list of these, if you made up a list of all of these factors that impact your pain, most people can see pretty clearly which of those are likely to turn up the dial on their pain and which are likely to turn it down. And so, I think, teaching people about this biopsychosocial model can kind of expand the picture of how they think about their pain, and sometimes give them a little bit of, I guess there are some parts of this that I control, at a time where they probably feel like it's all outside of their control.
Yeah, I think it's hard. As we have this conversation and I'm listening to that, I'm like, yes, this makes complete sense, of course. And I think it's hard for someone who they go to, pick up a box and they feel pain, in their leg. They don't feel anything shift or pop or anything like that, but they start noticing pain, and that pain progresses in their leg. And they're like, that makes sense what you're saying. But at the same time, it's hard for them to think that our brain is making all of these decisions and calculations and in that moment while they're doing it. I think it's hard for us to, it's kind of strange. It's hard for us to wrap our head around the fact that our brain is doing that much work, in these moments when we feel pain. And does that make it harder for them to kind of use this information?
I think everybody comes to this information at different stages of readiness to hear it. Examples I think are really helpful. The person who shares it with them are really helpful. And I think in my practice, the thing that always made it feel like an uphill battle was the language that and approach that they were getting outside of me. Because again, not everybody was approaching pain from this fully inclusive biopsychosocial place. You know, like their other providers might not be asking them about these other factors that might be maintaining their pain or keeping it chronic, and just saying, hey, let's try this injection. Let's try the injection again. Those injections didn't work. Let's try the surgery. And it's just like fix, medical, physical. And I'm trying to, on the sidelines, say, well, but there's these other things. And when we're only focusing on the medical or the fix, we're not participating in all of these other things that can help break the cycle. And so I think the play, so, you know, I'll give them education about, because I think studies have shown this, that people in pain want to learn. They don't at some point want to see the spine model again and talk about that. At some point, they just want to understand pain. And so that's where pain neuroscience comes in. I think that's helpful. The biopsychosocial model is helpful. But then when I walk them through what a pain cycle looks like, you know, that we have pain, that we start to avoid, that we start to become deconditioned, that we start to feel negative, have negative thoughts and feel negative emotions. We avoid more, we have more distress, we have more pain. And, you know, we talk about that in detail and what that looks like in their lives. And I say, this happens really easily. This cycle happens fast after acute pain, and it happens easily. And even though this happens, that's the bad news, right? But the good news is that within each part of this cycle is an opportunity to break it. And that's because there are so many factors different types of factors that can keep pain going. And so I think it's about listening to their story and not just lecturing them about this, but listening to their story and connecting the story with the education, because without that, I think their eyes glaze over and you're just another person who thinks you know how to fix them. Right.
Right. Yeah. And there's two parts of this that I think that I'd like to kind of dive into a little bit. You know, I'd say probably 30 or 40% of our listeners are in the medical community in some aspect. And then we have the other side, that the other, 60 to 70% are people who are interested in this because they've been an experiencer of pain or problems. So everyone listening to this will have been in this situation at some point in time where someone was asking them about pain, or they were asking someone about pain. And I think me and you were kind of communicating online about this, is that when we ask patients about pain, or we're being asked about our pain, what's the questions? It's like, where's it at? What's the intensity? What's the type of it? Like, those are the questions that almost without us knowing it, put us fully in that biological medical area, right? Yeah. So this was something I thought that would be fun to explore. Like, what should we be asking people about their pain? What are those questions that put us more in the real research of the kind of biopsychosocial model?
I think answering this question requires me saying that it's not just about what we're asking, because we can ask the right questions, but it's the language that we're using too, the language of the visit, the language of the diagnoses, the language of describing all of this to a patient. And I don't know if this would be helpful, but I'd love to share a personal story here, because I don't think my story is all that different from what other people experience, at least at the beginning. Because I went to my the snowboard incident, right? And 6 months later, I went to my primary doctor for like my physical or whatever. And I told her that I had neck pain for 6 months. I wouldn't go away. And she ordered whatever it was, X-ray, MRI. I went to her office so she could explain the results of that. And so she had my images up on the screen. She had the spine model next to her. She explained that I had a bulging disc and exactly what that was. And she didn't know. She said, well, maybe it was that whiplash from the snowboarding thing. And, maybe that was an injury that started it all. Maybe it was, maybe it's your posture at work. You're a therapist. You're sitting all the time. maybe you have weak muscles in your body or faulty movements. And so she referred me to a physical therapist, which, seemed reasonable to me. And I was also working with a pain management team in my job. So I had sort of these connections with, I saw several physicians. I did dry needling and acupuncture and saw a physical therapist. And I dove straight into the medical approaches for chronic pain. And I think the language in the visit that she used with me was really important, because first she explained this to me. And even though I knew what a bulging disc was, and plenty of my patients had them, and that instilled so much fear in me about my body, to know that there was a thing that was damaged. She also said that if my pain didn't resolve after trying different treatments, that I might consider speaking with a spine surgeon. And that was hugely fear-inducing for me. And because, I don't know, spine surgeons, maybe they don't necessarily only do surgery. I'm not sure. Maybe they do injections and other things. But it just, those words brought me so much fear. When I heard the words bulging disc, as she's kind of showing me the spine model and like my images, I had so much fear, and I couldn't get this image of a faulty neck out of my mind. This idea that something that wouldn't get better, it would only get worse with age, just sort of what was happening in my mind. And I'm a psychologist, and I was still jumping to the worst case scenarios, because this one visit instilled so much fear in me about my body. And I think this happens all the time, where patients present to their provider's office, well-meaning providers, with a goal to help them feel better. They get all of the diagnostic tests, their diagnosis, they learn about their mechanical issues, and there's no acknowledgement of anything else. And this happens really commonly. And I think that's where immediately that biomedical model is set in place. And biomedical has a really important, plays a really important role in the treatment of chronic pain. But by itself, I think we're missing the other two-thirds of the problem, which are psychological and social. Because when this biomedical model is set in place, we learn that the presence of pain is due to some kind of tissue damage, and that something is wrong physically. The language is often fear-inducing. The provider really focuses also on fixing, the bad disc, and then the patient and the provider are hoping that this treatment or fix will make it go away. So I talk to people after years of appointments, labs, tests, interventions, procedures, surgeries, medicine, physical therapy, with disappointing results, because there isn't one thing that reliably and consistently cures chronic pain, because pain isn't just a physical or biomedical thing, particularly after people have had it for years, right? Yeah. So, pain is biopsychosocial and exists in the overlap of all of those factors. And what happens when are these providers, again, well-meaning providers who are so important as part of their treatment, approach pain in this strictly physical or medical way, and normal conventional treatments don't work? How does that feel on the part of the patient? Or what happens when the cause for pain isn't seen on imaging? And I think a lot of patients, when we approach it this way, they are left to feel invalidated, marginalized, like their pain isn't real, or even like they're a burden. And I felt all of those things, because after trying many, many things, my pain still didn't go away. And I think that has to do a lot with the context of the period of time that my pain was happening in. And I could talk about that a little bit, but I'm just highlighting this story because none of my medical providers, and I know that they're limited with time, like, of course, but I think they can set the stage for people to explore a more comprehensive approach to their pain, because they never asked me about anything but the physical stuff. They never asked me about how much I thought about my pain. Was I ruminating about it, fearing it, avoiding my favorite activities? Was I feeling fulfilled in my life, enjoying my relationships? And I also wish that so if I could, and I'm not a physician, right? This is a bit outside of my scope. I'm not a physical therapist. It's a bit outside of my scope, but I wish that what I wish my doctor had said to me is that tissues heal and that hurt does not always equal harm. So I wish she had told me that whatever most cases, 80% of cases involving bulging or herniated discs heal within 2 to 4 months. Many tissues heal within 2 to 4 months.
Yeah.
I wish she told me that disc bulges are the most common finding seen on imaging. And actually, at my age at the time, much older now, she found that 40% of people my age had bulging discs with no pain, right? So that some of these findings are incidental and not necessarily the cause of someone's pain.
Had she told you, look, we see this is normal. Like, this is like looking at you. I love how you talk about like wrinkles, and like, we don't look at somebody's wrinkles and say like, oh my gosh, like there's a problem with your skin right there that we need to do something. There's damage in there. Here's what's happening to the collagen and elastin in your face. Like, no, we're like, yeah, of course it's there. I'm 50 now.
My goodness. Much gray hair on my head, and that bothers some people more than it bothers me, right? And these signs of aging affect us all differently.
Yeah, when we're having those conversations, it's so fascinating that we try and explain it exactly the way. And look, I mean, I have certainly been the person doing that in my professional career. And hopefully getting better at it, but it's always a work in progress, right? But if we have a problem and pain is meant to protect us, and we start to kind of generate fear around that problem, the explanation that did that actually reinforces the need for protection, because now not only do we have a problem, but now we're afraid that the problem might get worse or that it's actually bad. So we're telling our brain and our body, we really do need protection. So is that whole explanation of everything going on not only not helping us, but potentially increasing our brain's likelihood to tell us, no, you really do need protection. I do need to send these pain signals.
Yes, and because fear is one of the main drivers of continued pain. And so what if my doctor had said, like, look, there's a bulging disc there. Most tissues heal within 2 to 4 months. There's lots of factors that impact your pain. And don't fear, not to fear, right? What if she told me not to fear? But instead I did, and I tried all of the fixes, and when nothing worked, I feared even more, and I felt like a burden, and like no one thought my pain was real. And I felt like, I was going crazy because I had this pain that wouldn't go away. And so, unfortunately, I think the way that we approach pain, and that we've been doing it for many years, really just increases a patient's experience of like stigma about their pain that just won't go away.
Do you know of anything that would decrease somebody's, like, is there any habits, life factors that decreases their chance of experiencing chronic pain? Like, you can correct me, you'll probably know these statistics, but in research and stuff for our conversation, it still seems to be like 1 in 5 adults will be experiencing chronic pain. So 20%, what is that in America? What are we at? 400 million people? So whatever that is, 50 million people.
In developing countries, yeah.
So it's a lot. There's a lot of people who are dealing with this. Is there stuff that, like, does knowing this stuff on the front end decrease our chance of having chronic pain? Is there stuff that someone listening to this right now who says, like, this sounds terrible, I've never had chronic pain, and I don't want it. Do we know of anything that puts us in a position that our brain and our body are less likely to go down that kind of accelerated protection route?
Yeah, I think some of the more recent or leading theories about, and so I always think about, because pain's coming for all of us. We may all experience some acute injury or pain at some point. And I always think about what are the things that can cause acute pain to transition to chronic. And some general risk factors would be genetics. So there is some work that shows that sensitivity to painful stimuli and pain tolerability are impacted by genetics, adverse childhood events, presence of mental health symptoms, so anxiety, depression, catastrophizing, or worst case scenario thinkings would give a poor prognosis there. History of trauma at any point, co-occurring CNS symptoms. But I think, I read this paper and it said, most importantly, one of the the most important risk factor for developing chronic pain is pain itself, either acute pain or pain at another site. And the more severe the acute pain, the greater the number of pain sites, the more likely it will be that someone will develop chronic pain. But I think the risk factors that in my role, and that I think are most important for listeners to hear, are three things. So one is that can transition from acute to chronic, because we can't avoid always having a single injury in our lives, right? We will all experience pain. But so one is poor early education. So when an acute injury isn't adequately treated over time, the brain and the nervous system can get better at creating that pain experience. And if a person doesn't understand right from the outset about the brain's role in pain and pain as a warning sign and why it gets created and how it can get created and maintained, that can be really confusing for them. And I think if we can equip them early with just the neuroscience behind that, and it literally takes 5 minutes to explain that to someone, and of course longer depending on the person who's listening. But the second thing is fear, talking to them about fear, pain catastrophizing, and pain anxiety, because these things continue to trigger the fight or flight response and everything that comes with that. And that all goes back to biology, right? That in sustaining the pain experience. And then finally, hypervigilance on pain sensations, because this wires that pain response deeper and deeper into our neural pathways. And so, education and helping patients understand the role of fear, I think would be the most important pieces here if we're thinking about brief doctor's visits. And if we had 5 minutes to instill the most important education in our patients, I think that would be it.
Gotcha. So just to kind of double click on a couple of those. So the early education, would that be going through kind of the biopsychosocial and how pain works and kind of what we talked about at the beginning of this, them understanding that early on in an injury?
I think so. I think, and even just to start with the pain neuroscience behind it, because I think explaining to them how pain is in the brain, how context matters, how we can, remind our nervous system and our brain that we are safe. Pain isn't necessarily a sign of damage. I think even just that neuroscience piece can be really important. And then, of course, the biopsychosocial model, introducing all of these different factors that can impact their pain. So
if somebody's saying, I know that I'm going to have some sorts of acute pain in my life. And for the reasons that you led off the show with, we want you to have acute pain at times. If there's a problem there, that's how your body is protecting you. It's a good signal when appropriately used by our body. But and they start to say okay, I know right now, having watched my friend, my dad, my grandfather have back pain, that I'm afraid to have back pain. What can they do about that? Because, as you said that, then they fall into genetics, and we know the vast majority of people are going to have back pain at some point in time. So they've got kind of two strikes against them a little bit. So if we know that fear is a big part, how do they okay, I don't want to end up with chronic back pain. What can I do to kind of change that fear avoidance knee-jerk reaction that I have kind of built into me?
Yeah, I think that's really hard. And of course, it takes more than one conversation. But I think, when we think about pain neuroscience as teaching patients explicitly what pain is and the process of how our brain creates that experience of pain as the body's warning system, and that this system, though it's designed to protect you, it's evolved that way, it can sometimes become overprotective or faulty. And so the most important piece there being, telling the patient, if your brain believes there's a threat that makes you vulnerable, whether that's this MRI your doctor showed you, or the spine model they brought up, or seeing your dad in pain all of his life, if your brain believes there's a threat that makes you vulnerable, it will protect you by creating pain or more pain. And when the brain believes that you are safe, it won't need to create pain to protect you. And so, what are the ways that we can communicate this to our brain. And so, when I have more time with someone, I would go through all of these biopsychosocial factors with them, and we can divide them, right? Things that are communicating danger to my brain and things that are communicating safety to my brain. And how can I switch those to safety, right? Or how can I up the ante with the safety system, safety pieces? Because overcoming chronic pain or keeping it from being maintained is about resetting that warning system, which might be sensitive from the onset, or it might be sensitive for different reasons, which has become too sensitive, right? So moving that person's conceptualization of their pain from danger in them to safety in them. And I think the best way we can do that for someone with chronic pain is to educate them on what pain is, how to turn down the sensitivity of their nervous system and reduce that level of threat perceived by the brain. And I have to say that when I was practicing clinically, I would ask people at their intake with me, and by the time I see them, this is years and years of pain, because no one's seeing a psychologist at the outset, right? That's just not a thing, unfortunately, that we're doing. Well, we were trying to do that, but most people hadn't. And I would ask them, has anyone ever taught you about what pain is? And I think literally no one answered that question with a yes. And so nobody.
And we wonder why we have 50 million people in chronic pain.
Yes, right. And that's, I think there was a study that said that, I don't remember exactly the number, but something like 80 to 90% of medical schools in the US and the UK have no chronic pain curriculum built in. And so these are the people, and so maybe they have pursued that on their own. Maybe they did get a little bit, I don't know, but that's what the study said. And so these are the people that we depend on treating us for pain at the outset.
Yeah, and you kind of answered this, but I think maybe let's kind of at least kind of put a bow on it. Is like one of the questions I have as a pain specialist is, we read the studies around how pain education changes people's pain experience. And it was always kind of something in my mind is like, what is actually happening whenever we educate them? And I think at least part of that from what you were just saying is the safety part that their brain starts to create if they start to understand that. But is there anything else that's happening when we educate a patient about pain? Because I've seen those studies. I don't remember exact metrics, but it's like after a pain education, even like a post MRI showed a different result of how their body was processing signals. So what all is going on in there with that?
I think we're thinking of the same study, because I think they had, and this might be slightly off, but I think they had, someone who was a professional dancer kind of laying in an MRI, and they asked her to think about her pain, and all these areas lit up. They asked her to think about moving or doing a certain activity, and all these areas lit up. They give her 10 minutes of pain neuroscience education. They redo the MRI, and there was a lot less areas lit up. And I think, what it's doing is it's neutralizing it, because all of the language is fear inducing. Even the names of some of the diagnoses we give people, right?
Degenerative disc disease.
Yeah, or like bone on bone, or like, a tear. Every bit of it is fear-inducing, and for some people. And so I think the main thing it does is that it neutralizes it. And we know that when we neutralize we know that the way that we think affects how we feel emotionally. We know that the way that we think affects how we feel in our bodies. These things are all connected. And when we can neutralize our thoughts or make them less negative or less fearful, that's going to impact everything on the way down. Our emotions, our sensations, our biology, our fight or flight. It impacts everything.
I had a very crazy case. And this was probably, if I really think back to it, one of the early things that started to make me, a bit more inquisitive about these things. But so currently we have a pain specialty practice in Louisiana, but previously I was practicing in South Alabama, where there's a lot of people who just, the education was not very high in healthcare kind of education in that area. And one of my patients came in. I had treated her twice, and she came back for a third visit, and she's like, I feel amazing. Like my back feels great. I'm not having any problems. And of course I'm thinking I'm early in my career. Like, man, I know what I'm doing. This is going to be amazing. So what happened? And she had like I don't want to say like, she had a woman that she would go talk to, and she would basically like give her kind of advice using different methods. I don't want to say it was like tarot cards, but it was in that realm of things. And they go through some things, and she brings it up, and who knows where this is coming from, but her little person says, oh, and you've been experiencing pain. And she said, yeah. She starts telling her about it. She said, well, it's actually going to be fine. It's not going to be a problem in your life. And it was gone. She's like, and so she comes in, and she's like, at the moment, it's just like, should I keep coming? I don't know what to do with this stuff. But you look back at it, and you're like, this is someone she trusted. And the way they're having the conversation is it's somewhat future knowing in some capacity. And it's like, hey, everything's going to be fine. Your back is healthy. It's good. And I think of that now, and I'm like, how much that checked the boxes, that you're safe. It's good. You're healthy. Everything is on the right path. Your body's doing what it's supposed to. I'm like, it did so many things right in terms of treatment, that of course she comes in and she's like, this is the best it's felt in ages. And I'm like, look, we want to be 100% honest always with our patients. But I'm like, golly, can we not get a little bit of that into our communication system?
I think that's such a great story that sort of reflects how strong language can be, how much our words matter. And I think that's a really fine line for people in the medical field to have to walk, because, they can't guarantee someone's going to be fine. Yeah. Right. And they need to educate their patients and fill them in on what's going on. And I don't know the balance of that in that role, but I think it should challenge us to all think about the language that we're using.
Yeah. I think if anything else as practitioners, if we can just start to pay more attention to that, and can you use more language that induces some version of safety, how much would we change on these things? Because of everything that you said, I can't think of many medical diagnoses that aren't fearful, even for us as people in this world, right?
Yeah, absolutely.
So when we're going through some of this stuff, and someone is already there, so I'm already in the kind of chronic pain situation. What are the strategies at that point? So like once we get in there, what are the things we can do to maybe unwind some of this stuff?
Yeah, I mean, so when I was practicing clinically, it was as a psychologist, right? And the big question was always, can pain symptoms be resolved by psychological treatment? And I think the main psychological treatments that we see for pain aren't really necessarily going for resolving symptoms, at least that we've researched a lot. They're not really targeting the resolution of pain. They're targeting things like quality of life, living better with pain, reducing pain severity, increasing sense of self-efficacy, kind of that whole self-management of pain. And even like, CBT is this empirically supported talk therapy that's been around since the 60s, and they use it with everything, depression, anxiety, and it's really effective. But I think it's kind of tough. People are looking for an answer and a resolution of their chronic pain. So I think people with chronic pain should try, and with that said, I've seen it help reduce pain intensity for people. Absolutely. It's quite effective. But I think that people with chronic pain should try all of the things and see what feels good for them. I mean, so for some people that might be mindfulness and paying attention to their sensations and reappraising them, CBT, acceptance-based approaches. But it's important to understand that the focus of some of these treatments is less on overcoming pain per se and more on increasing, like I said, self-efficacy, learning how to manage it, reducing distress and negative emotions. But I think when we're talking about someone for whom there's this strong evidence that there might be neuroplastic pain at play or their nervous system is highly involved, there has to be education that does that shift of thinking from danger to pain really early on, and understanding the cause or what's driving their sensations for them personally or uniquely, reducing that fear of pain, reducing avoidance, getting them out of that continual fight or flight mode. I think if we want to be able to change pain, we have to reduce fear and give them the knowledge and the control to change their brain's response to those signals. So I think that should be directly targeted and a major focus for anyone with neuroplastic pain. And I think once we do that, we're more likely to see people engage in psychological. So imagine if they've gotten that, then they're more likely to engage in psychological treatments where they can learn skills that turn down the volume on their pain and communicate safety. They might be more likely to participate in physical therapy, whereas before, I mean, I had a lot of patients say to me, I went to therapy and they, manipulated my body and they had me do these exercises and it made it worse. And now I'm afraid of my pain and I'm afraid to do the exercises. They're more likely to use active coping skills. And they're more likely to feel empowered. So I think it's just, that needs to be a really early piece of it. And then it can sort of enhance their participation in these other things.
Yeah, I think of this and I'm always trying to how can we integrate these things to get better results for our patients? And in our office, we're always trying to do two things, especially with chronic pain. Can we improve the tissue health and function that they come in with, and then can we help their brain and body relearn safety and maybe decrease protection? So we're always telling them if we can achieve these two things, then everything is going to be just fine, everything's going to be great, you're going to live the life that you deserve and you want to live. I wonder if there's not this Goldilocks zone of, there's all these advances coming out in regenerative medicine and stem cells and peptides. And I feel like pain education has certainly continued to level up over the years. And people like you having these conversations is definitely helping that. And then, looking at prevention also, which we kind of dropped for 100 years and just said, no, modern medicine's going to take care of it. Don't worry about that. I wonder if there's not a Goldilocks zone where we're doing all of these things right. Is there a world where chronic pain is not affecting 20%? Is it completely resolvable? It's always tough to say something like that, but how much better could we get this kind of chronic pain field?
I think that is possible, and I think that zone exists in that biopsychosocial model but the problem is that each of us, right, we're all treating it within our specialties 1/3 of that 3-part problem, biopsychosocial, and we're not talking to each other. And the most effective I ever felt was when I was running this interdisciplinary pain program alongside, and I'm not talking we each did our own things, alongside together a physical and occupational therapist. If a physician had been there, that would have been awesome, but they were part of it, but sort of, in the background, because when you're doing it together, patients are getting all of that information at the same time, because there are things that within my study as a psychologist, I can't speak about as strongly as sort of the physical therapist would. And the physical therapist was super uncomfortable with talking about anything psychological. But I will say, I think, I think we need to talk more. And I wish that healthcare was designed so that I was at a VA, so it allowed us to kind of do things our own way, because that system is a little different. But, we need to talk more. We need to work together more alongside these patients. And I don't know if this is okay to say, I sort of feel like physical therapists are leading the charge on that, or can lead the charge on that, because they have so much knowledge about the body and pain, and they're seeing patients so early, and they're still in that physical realm. I feel like they hold this really unique, and physicians, this really unique position where they can transition them or help them reconceptualize their pain in a different way.
One of the things that I've seen, at least in that world of like, you know, kind of the physical therapist being able to lend a bigger impact on these things, is the frequency creates a relationship. You know, there's a deeper social relationship with patients whenever you're seeing them a few times a week. And just the way that model's set up, it's harder for you, you know, for a physician who sees somebody once a month, for you to really get pulled in and understand how this is affecting their life. And so you can kind of say, look, you know, if the medicine's not working, we'll move to the next step. And it's a little bit easier for you to have that one step removed, where you don't realize like, this is important. We need to dive into these things, and they need to understand it, because this is truly affecting everything that they're doing. They can't pick up their grandkids, and like now they're experiencing depression. And when you build that relationship with them, you know, hopefully the reason you're in that is you're like, I'm really driven to help this person, and just staying in the biological model and not helping them through these stages that we've talked about today is not serving them in the way that we need to serve them. So it's a unique benefit for you know, people who are in that situation to help patients like that. Is there any, like, we always want people to have a couple of like strategies. Is there some, whether it's visualization or exercises or anything that that your patients have really latched on to, that you found were really beneficial that people could try?
Yes. I mean, so I think these things are most helpful after they've gotten sort of that basic neuroscience
education.
I think for me, clinically, the two things that stand out are teaching people about pacing and helping them become more aware of their thoughts and beliefs around their pain. So pacing meaning, you know, kind of designing their days differently, because a lot of us, for many reasons, whether it's people pleasing, perfectionism, or just, you know, whatever, we push through the pain, we push through our day, we ignore all the signs, and then we crash at like 5 p.m. And then we are immobile with pain for days sometimes, and we have a flare up, and then it's just a cycle of that happens over and over. Or we're afraid to move and we stop moving, and then we become so deconditioned that we can't really do the small things we need to do every day, and we have constant flare-ups, right? And so I think teaching people how to pace their day differently so that they can be more productive without the flare-ups and the crashes. But, you know, I also think that for people with chronic pain, negative cognitions hold a really powerful role. And especially when pain fails to improve over time, we can typically see a person's thoughts become increasingly negative and holding more and more influence over their pain and that pain cycle. And it's important, I think, to say to them also that all human beings have thoughts, automatic negative thoughts. Or automatic positive thoughts. We all have these thoughts that come out like reflexes, and research shows that negative thoughts are directly associated with pain perception, but negative thoughts are often also automatic. They happen outside of our conscious awareness. They've sort of become like a reflex. And it's important, I think, to state here that thoughts are not the cause of your pain. Your pain is not all in your head. It's not real. But many people have been made to feel like they're exaggerating their pain, or that it's psychological. And so I always make sure to say that. But I think two things can be true, that all pain is real, and unhealthy thoughts can negatively impact someone's pain experience in indirect and direct ways. So we think of negative thoughts like when I was saying things that can turn the volume up and down on pain. Negative thoughts are one of the most robust and reliable predictors of increased pain intensity and more disability. So it's important I think, to address them. And so the way that we do that, because I think most people can recognize that they have these automatic negative thoughts and that they would increase pain intensity or they would increase stress or negative emotions. And, one example of that is like if you're sitting waiting for your doctor, a lot of thoughts can come up in that scenario, right? Like, I hate waiting. My doctor's always late. My pain's getting worse. Nothing's worked before when I've sat here. Why would it work now? I can't do anything with pain. I can't even sit and wait for my doctor. So just sitting in a doctor's office can increase negative thoughts associated with that experience and evoke an emotional response. And so I think, we might start by explaining all of this to patients, that automatic thoughts are a normal part of being human. The presence of pain can set the stage for having more of them. We find that as pain gets worse, thoughts become more negative, and they can get in the way of coping in an effective way. So we can explain this to patients and maybe start by asking, when you're in pain, what kinds of thoughts go through your head just before or during that moment. And the most common types of thoughts that people will tell me about is something we call catastrophic or worst case scenario thinking around their pain. And this type of thought in particular is a pretty reliable predictor of emotional stress and pain intensity. And this shows up often as ruminating about pain. I can't stop thinking about how much it hurts, magnifying the pain. My pain will get worse. I won't be able to work. I won't be able to provide for my family, and helplessness. This pain's never going to go away no matter what I do. So if we can really get to the heart of what these thoughts are, especially if the person can't recall them easily, that can be really helpful. So, what I would ask people is, what's the thing you're most afraid of? What happened in that moment? What's the worst thing that could happen? What memories does this bring to your mind and body? What does this mean about your future, your life, your health? And I think in CBT, we call it catch it, check it, change it. So you catch the thought, you check it and decide, is this something that's helpful or unhelpful? Where did it turn the dial or the volume up or down on my pain? And then change it by creating a thought or writing down a thought or saying something else out loud that's less fear-inducing or more neutral. So I'm not talking about like faking positivity, and it takes practice, like writing it down. Like, can you practice writing down a way of thinking that's more neutral? And we're creating new pathways in the brain by creating different ways of thinking about this. If that makes sense.
I love it. Yeah, absolutely. That's fantastic exercise. I remember hearing someone along the way say something like, a lot of times, like, chronic pain is, when they explain how bad it is, it's not necessarily, if you really could get down deep of what they were feeling in that moment, it's not that their pain was that bad right now, but the fear that it might get worse or what it would mean for them in the future is really what they were telling you. Like, my pain's a 9 out of 10, but they're sitting there straight faced, and you're like, in this moment, you're not feeling, such severe pain that you're about to pass out and need to be in the emergency room. Mm-hmm. But what they're telling you is that, like, my fear of what this means about me or what this means about my future with pain is a 9 out of 10. I thought that was very profound, but I love the catch it, check it, change it. That's probably something I think everybody, even in the early stages of pain, need to really start to do. You start having pain and you start treating it like that of your thoughts around a sprained ankle even. Probably super, super helpful in the beginning to start thinking like that every time you have a thought about, does this mean I'm not going to be able to run? Like, that's not helpful. Okay, what else could I replace that thought with that might be more neutral? Or is it more neutral or empowering would be?
Yeah,
anything.
I don't want to say anything but like a positive thought, right? Because that's hard for people in this scenario to come up with something positive. So
right, yeah, that's why I say that.
Yeah, more neutral, more empowering, less fearful. And, I think that part can be really challenging for somebody, but if you can get in the practice of just being aware of the thoughts that are popping up and noticing them, because like I said, they kind of happen like a reflex, people can start to kind of notice patterns of how they're thinking about pain and sort of probably everything. And a lot of us think that things happen to us and they cause us to feel a certain way, but actually right in the middle of those two things is the way that we are thinking about or appraising that thing or sensation or whatever it was. And that is what determines how we feel about that sensation or situation, right?
Yeah. I'm going to put this out because I'm sure that all this content has been amazing. Like, I feel like as people go in, even there's going to be little snippets that are really, really powerful. If y'all have questions, please like tag us. I feel like we're going to have to do a round 2 at some point because I had like 7 pages of notes and I think I got through like half of them. Not half the pages, half of a page.
Yeah, no, it was so fun. I'm so glad we got to have this conversation.
Yeah, thank you so much. This is a blast. Where can people kind of find your information, follow that, get more of this stuff?
Yeah, I'm on pretty much all social medias, but I think the place that I'm most active where people can get, some free kind of digestible bits of education is on Instagram. I'm Dr. Anna Redmond, Dr. Anna Redmond. And so I try to put a lot out there for free. I think people deserve a certain amount of education about their pain. And then if you go to links.dranaredmond.com, I have a lot of resources and I'll be coming out with a lot of stuff this year. Like I have a digital course that's just a quick 45-minute thing that kind of gives people a little bit of that background, that history you were talking about, why we as a society have approached pain this way. And here's a different way to look at your pain, sort of the 10 minutes of critical education I think everyone should hear. And other resources I also have on that link as well.
Nice. Yeah, we'll throw those links in the show notes for everybody. Okay. Definitely go check that out. Links, like the word links, Dr. Anna Redmond.
Definitely.
Is that right?
Yeah, I'll send it to you.
Okay, beautiful.
Yeah, links.dranaredmond.com is where you can find everything.
Awesome. And we ask all of our guests, if you could tell people one thing that they could do today to improve their health, what would that be?
To improve their health? Mm-hmm. I'm just going to go back to the thing that I say over and over is think about it from a biopsychosocial standpoint.
I love it.
And pick the low-hanging fruit. Like, what can you change right now and what might you change later?
Awesome. Dr. Anna Redmond, thank you so much. This has been a blast. I hope everyone has gotten as much out of this as the notes that I have on it already. Grab myself, grab Dr. Anna on Instagram or wherever you can find us. Throw your questions out and tell us your favorite part. But thank you so much, Anna.
Yeah, thanks so much for having me. I appreciate it.